Hello everybody, welcome. I'm so glad to see so many of you here today. I know some of you, but obviously not all. So before I give an overview of the study results, which is obviously what you're here to hear about today, I'm going to start by just acknowledging the team. So you've got myself and Nick, who will be speaking today, giving you an overview of our results and our findings. We've also got Sinead and Grace, who will be familiar faces to a lot of people in the room because obviously Sinead and Grace were out collecting a lot of the data across all the homes. We've also got Madeline, who's sitting in the middle here. Madeline joined our team a little bit later than everybody else. Madeline's an occupational therapist and has been particularly involved in the talking mats and also giving some feedback to homes around the study findings. And we also have Jacinta, trying to see where Jacinta is, next to Sinead over here. And some of you will have had conversations with Jacinta. Jacinta's been chasing up information, doing manager debrief interviews. So even if you've not met Jacinta, you probably have had conversations with her. So that's been the wider team. So let's have a look at the project. So I'm just going to give you a quick recap. So the project was funded by the NIHR School for Social Care Research. We've got a website there for those of you that are interested in finding out more about the kinds of projects that this funder funds. It was a 3-year project starting in 2015. It was actually due to end around the end of April this year, but because we've had such an overwhelming response from homes, we've actually extended the project till the end of this year so that we can really make the most of the findings and share our findings with as many people as possible. Okay, so let me just remind you all about the aims of the project. So the first aim was to understand the impact that care homes and nursing homes are having on people's quality of life. So we weren't looking at health, we weren't looking at that kind of thing, we were specifically focused on quality of life. The second thing that we were looking at with this project was the relationship between residents' quality of life and the new CQC star ratings. So those of you that work in homes, managers, will be very familiar with the fact that at the end of 2014, CQC started re-inspecting care homes. And that has gone on until the beginning of February 2017 was the last one that they did. So all homes have been re-inspected during that period. And these new star ratings were a bit of an unknown entity in terms of the relationship between that and resident outcomes. So that's something that we've been really keen to look at and I'll be talking about this afternoon. And then finally, the last aim here is to look at the relationship between quality of life and when we collect that data. So a lot of the research that goes on in care homes tends to happen in office hours, Monday to Friday, between the hours of 9 and 5. And it occurred to us that with care homes being entities that run 24/7, every day of the year, that actually we were potentially overlooking quality of life issues that may be happening outside of those hours. So what happens when we go home? And Nick's going to be talking about that in the second presentation, so I'm not going to touch on that at the moment. So what did we do? Well, lots of you in this room will know because you took part, but just a little recap. So we invited a selection of homes across Kent and Medway to take part in the research. We were aiming for 30. We ended up with more. We wanted between 5 and 10 residents per care home to take part in the research. So we were aiming for around 300 care home residents altogether. For every single resident who took part in the research, we asked key workers or members of staff who knew them well to complete a questionnaire about their healthcare needs, their characteristics. And we also did interviews with residents, interviews with family members and interviews with staff. So many of you would have taken part in those interviews. And finally, we carried out observations. So you would have seen us walking around the home, standing in the corners, and we did those in the communal areas. So we often observed in the lead up to lunchtime and over the lunchtime period so that we could see a mealtime. And sometimes you would see us walking around in the afternoon if there was a particular activity going on or something that we felt was of interest from a quality of life point of view. So I've said that we focused on quality of life, but that's obviously quite a broad concept. When we say quality of life, it can mean different things to different people. And the way that we define quality of life is that we look specifically at the areas of quality of life that are most influenced or affected by social care. And to do that, we use something called the Adult Social Care Outcomes Toolkit, or ASCOT for short. So those of you that have taken part in our interviews will remember that we worked through a series of questions around different areas of quality of life. And they were 8 different areas or domains. The first 4, personal cleanliness and comfort, food and drink, personal safety and accommodation cleanliness and comfort. And they're what we call basic domains of quality of life. So these are aspects of your life that if your needs are not met very soon within those areas of your quality of life, you would suffer quite quickly health consequences. If you weren't safe, if you went without food or water, it would affect your health very quickly. So they're very important fundamental domains. After that, we have control over daily life, social participation and occupation. And by occupation, we mean how you spend your time, so being occupied. And those are what we call higher order domains. And by that, we mean these are the domains of quality of life that add quality to your life. Without those domains being met, without your needs being met in those areas, you might feel depressed, bored, lonely, isolated, like you have no choice or control over your life. So they might not be as fundamental to health in the traditional sense, but they're absolutely fundamental to quality. And finally, the 8th domain there is dignity. And we all share a common understanding of what we mean when we talk about dignity. But again, in ASCOT, we have quite a specific definition. And by that, we mean how the way in which you are treated, so the way in which you're treated by staff, by people that are coming into the care home, how that makes you feel. And again, if you think about that, it's something that really affects your quality of life and the way that you think and feel about yourself. If someone treats you kindly, with respect and with compassion, then you're going to feel comfortable receiving help. You're going to feel unafraid to ask for help. If someone treats you roughly, without a care, and as though you're an inconvenience, then you can see how quickly that's going to make you feel maybe ashamed, too afraid to ask, and quite low in your general mood. So it's something that's really important. It's a domain that's of significance to people receiving social care. Okay, so we use that structure, if you like, that framework to collect data about people's quality of life. Those were the areas that we were looking at and focusing on. Altogether, we got 34 homes that agreed to take part in the research, which is a really good number, and it was more than we anticipated that we would get. It was actually 29% of the people that we actually approached that took part, which doesn't sound like much, but it's all right actually as far as research goes. It's pretty typical. So you can see the amount of work that we had to do just to get to the point where we were going into homes, because actually 85 said no. And those 85 still had to be spoken to and met with and talked to on the phone and so on. So it's quite a lot of work just to even get your foot in the door, if you like, with care homes. So how many of those were nursing? We had a mixture of nursing and residential. Unusually for the research that we normally do, we actually had more nursing than residential homes in our sample. We've tended in the past to experience the opposite pattern. I'm not quite sure why that was. But this time, out of our 34 homes, 20 were registered for nursing. So we had a slight bias towards nursing. Now, some of you may be familiar with this term, and others this will be new to, something called research-ready homes. Or have anybody here heard of the Enrich website? No, the Enrich network. So the NIHR, which is the National Institute for Health Research, supports a network which is all about helping care homes become research ready. And by that, it means not just focusing on homes and encouraging them not to be frightened of taking part in research and reassured by it, but also about encouraging researchers like ourselves to engage with homes in a more positive way, to encourage and facilitate people to take part in our research, because it's an area that traditionally has been very, very, very difficult to recruit to. And studies frequently fail in their ability to work with homes and encourage homes to take part in research like this. So it's a really big, important area in terms of how can we get care home managers and care home owners to engage with research projects like ours, so that we can learn and share that learning. So of our 34 homes, 7 of the 34, when we began recruitment, were registered on the Enrich website. So they were already research ready, if you like. So not a huge proportion, but some. And interestingly, after taking part in our study, another 4 became research ready and were added to that network. So that's really good news, and I hope that maybe by taking part in projects like ours, it encouraged people to consider themselves ready for other projects in the future. We've actually got a representative here from Enrich today, Margaret, who's sitting in the audience. And I did say that I would just introduce her to you, and there'll be an opportunity at the end of the sessions this afternoon for everybody to network. We're going to have a bit of food coming in. So obviously if you want to speak to Margaret and find out a little bit more about how your care home could become research ready, then I'm sure Margaret will be happy to talk to you, or delighted to talk to you. So that's a little plug, because I think it's really important that researchers, the Enrich network, and also care homes are all supporting each other so that we can do more events like this and more projects like this in the future. And that's the website for those of you that are interested. And we will be able to forward these slides, and all of this information will be going online, so it will be publicly available afterwards. Okay, so let's get into the nitty-gritty then. Let's have a look at what we've got. So the care home CQC ratings. The first thing that we had to do when we were looking at the analysis, and I'm looking at Sinead because she's been heavily involved in all of this with me, is we had to work out, is our sample representative? So let's have a look at all the new ratings across the country. Let's have a look at our 34 homes, and let's first decide how representative our sample is. So that was our first step. So, as I said, they've re-inspected. Oh, one of the things that I should mention is we were struggling to get the tail end, and this is always typical. There's not many homes in the country that are rated, thank goodness, as inadequate. But that was something we wanted to try and do. Could we manage to recruit a home that was struggling? And we did. But as is the difficulty with this kind of research, as soon as we'd recruited a home, sometimes the rating would change because they'd be re-inspected. So this is just working within the real world. So we managed to recruit one home that initially was rated as inadequate. A week after fieldwork, they were re-inspected and they were rated as requires improvement, which is brilliant and is what we want. But we were kind of chasing our tails a bit here with the sampling. So here is the national picture. If you have a look at this chart, the blue bars there, that's what the picture looks like across the country. So this is all homes, nursing and residential, lumped together at the moment. So if you have a look at inadequate at the bottom here, thank goodness not very many homes are rated as inadequate. 2% nationally, and of our sample it was 3%. Then requires improvement. Again, 20% nationally rated as requiring improvement. 26% of our sample were requires improvement. So we oversampled a little bit there. And the reason that we did that is because we still needed a certain number of homes in those categories just to be able to say anything meaningful about it. And then the most homes are in the good category for both the national picture but also for our study, so that's good. And then we had slightly more outstanding homes for exactly the same reasons that we had slightly more around the requires improvement. If we only had 2%, it wouldn't have been very much for us to say anything about it. So we had to go for slightly more in that category. But reasonably representative. Let's have a look at the difference between nursing and residential now. So this is nursing homes only now. And as you can see, it's got broadly the same pattern, so most homes being rated as good. We had a little bit more of a discrepancy amongst nursing homes towards outstanding. So we've got 10% of our nursing homes as outstanding, whereas actually 2% in terms of the national picture are rated as outstanding. And then in residential homes, we've got a very similar pattern again. So broadly speaking, we've got similar. Slightly more requires improvement there and slightly less on the good. But we needed to reach our minimum numbers. So nothing really for us to really be concerned about in terms of how representative our sample is. So let's talk about the residents that took part. Altogether, we managed to get 293 residents, which was really good, and it's probably the best that we've done in recent years in terms of recruitment. So thank you all for agreeing to take part. Most of them are women, which is typical of care homes, 67% women. And our average age of people in our sample was 85 years old. But what an age range we had. So between 50 and 103 was one of our eldest residents. Most were white. Well, we did it in Kent and Medway, it's a largely white area, so that's probably not that much of a surprise. And 27%, so a quarter, were married or were living as married, if you like. They still had a long-term partner. And around half had dementia, just over half had a diagnosis of dementia. And all of you that have spent time in homes will know that although half might officially have had a dementia, actually probably more had some levels of cognitive impairment as well. Okay, so whenever we're doing research like this, one of the things that we have to do, we're interested, if you remember, in looking at things like the relationship between quality of life and CQC ratings. But we've got nursing homes, we've got residential homes, we've got people of different health needs, people of different ages and backgrounds. So we have to control for all those different things when we're doing the analysis, so that we can start to sort out what is causing what and what's affecting each other. That's really important if you want to try and understand the results that you're getting. So some things that we noted, mainly around the difference between nursing and residential here. So if we look at nursing, compared with people who live in residential care homes, the people who were living in nursing homes were younger, more likely to be male, more likely to be married, more likely to have a diagnosis of dementia. They were in poorer health, well that is what you would expect in a nursing home. They were less likely to be able to self-care, again, pretty much as you might expect for a nursing home. And they were less likely to be funding their own care, and that probably has a lot to do with the fact that they were receiving NHS funding as much as anything else, not just the social care element. So these are all differences that we had to consider when we were doing our analysis, and we had to, if you like, control for when we did the multi-level modelling. So one of the first aims of the project was to look not just at residents' quality of life, but the impact care homes are having on that quality of life. So that's what I'm going to talk about now. So if you have a look here at this chart, as you can see, round the outside are our different domains. Now on the far side of me, so on that side, as your right, as you're looking at it, you can see accommodation, personal cleanliness, food and drink, and safety. So those are those basic domains of quality of life that I was talking about a minute ago. And you can see that blue area. And the blue area is quite far towards the edge of that chart, isn't it? It's not very far in. And what that tells us is that in care homes, people's quality of life is really good in those areas. So care homes are doing a lot for people in those areas of their lives. If you look on this side, so my side of the chart, we've got control over daily life, occupation and social. Now if you have a look, the chart's a little bit lopsided to the right. So the care homes are doing less. The blue line is further in around those higher order domains. They're still blue, homes are still doing a lot for people, but it's not as far over as it is on the basic domains. So it starts to tell us where homes are doing more for people, which areas of people's lives are being helped the most by care homes. So that's what people's lives are like now. But what does that tell us about the impact of the home on that quality of life? It doesn't tell us much in and of itself. They could be having that quality of life because they're fit as a fiddle and they can care for themselves, or it may be that their family members are coming in and doing a lot for them. And the way that we look at the impact that the home is having is we go through a long exercise where we collect the data and we do interviews and we do observations, and we estimate what that person's quality of life would be like if they did not have the help and support provided by the home. And we don't just pluck that number out of the air. We do that by collecting all the data that we do while we're through the interviews, through the observations, through the questionnaires that people have filled out. And that data is put together and we come up with an estimate for each of those domains. And if you have a look here, this red circle in the middle, this is what people's lives would be like if they didn't have the help and support that they are getting from services, so from staff, from the care home. And the difference between that little red area in the middle and the big blue area is the impact that care homes are having on people. And you can see that impact is significant, isn't it? So what it tells us is, if you were to take the average person living in a care home now, today, and take away all that care and support, they would have a very, very poor level of quality of life. And that's something that I think is really important to acknowledge and remember, that just the significant amount of care and support that's going into people's lives and what a positive effect it's having on people's lives. So that's for our sample. If you have a look here on the other chart, it's exactly the same thing, but it's based on a whole national sample of care homes. So the data's a little bit older, it's from 2010, but it stands the same. And if you broadly look, the shape is very similar, isn't it? You've still got a bias towards that basic side, so the accommodation, personal cleanliness, food and safety. That's where care homes were doing the most for people nationally. And a more lopsided around control, how they spend their time, which is occupation and social. The one thing that I do note though is the red area has got smaller. So if you have a look at the red area from the 2010 data, it's slightly bigger than the circle that we've got for the MOOCH data. And I think what's happened is that over the last, the actual data that we use there, although it says 2010, it was probably collected around 2007, 2008. And actually, over those 10 years, what that tells us is that the population in care homes is probably becoming a bit frailer. And that won't come as any surprise to any of you that work in homes or own homes. And so the quality of life without help and support is getting smaller because people need more help and support now. So that's what that tells us in terms of impact. Homes are having a huge impact. All areas of life. And without that care and support, their quality of life would be worse across the board. But there is still a little bit more work to do around those higher order domains, so social, occupation and control over daily life. Okay, so let's move on now and think about the CQC ratings. So this was our question. Do people living in outstanding and good care homes, as rated by CQC, have a better quality of life than people living in homes that requires improvement or inadequate? Yes is the short answer. So our analysis, we've looked at lots of different things in our analysis, and it's been quite complicated, but broadly speaking, on average, people living in homes that are rated as outstanding and good do have higher levels of quality of life, looking at those 8 domains, than homes requiring improvement or inadequate, even after we control for all those other factors. So these are things that we found were important when we looked at people's quality of life, and we had to allow for these factors, otherwise the results might look a bit different. So we had to control for people's health, so that makes perfect sense, doesn't it? We had to control for marital status, and that may well be linked to things like how much support people are getting in terms of informal support. We controlled for age, because that is a factor, and that was also a difference between nursing and residential, so it was important to include when we did the statistical modelling. We had to control for behavioural symptoms of dementia, so how well people's behavioural symptoms were being managed every day. Whether or not they had a diagnosis of dementia, that has a significant impact on their quality of life. The type of home, so nursing or residential, was important, and also the size of the home, whether it was a very large home or a very small home. So these are all things that were important for us to include, which is why when we came out and visited all your homes, we collected all that background data, because we knew these were things that we were going to have to consider when we did the analysis. So let's have a look. So these bars represent people's quality of life. The higher the bar, the better the quality of life. And if you have a look on this side, we've got outstanding and good homes, and look how high those bars are. So the blue homes are residential care homes and the orange bars are nursing homes. If you have a look at the outstanding and good, we've got scores right up here, 0.8 and 0.78. And although there is a slight difference, that's not a meaningful difference. So don't read too much into the difference between nursing and residential there. They're basically the same. So in outstanding and good homes, we've seen very high levels of quality of life. In homes that require improvement, and we've put our one inadequate home into that category as well, because it did get rated up a week after our fieldwork. We've still got reasonably good levels of quality of life actually, 0.71 and 0.72. I know they sound like meaningless numbers to everybody else, but actually they are good numbers. They're reasonably good numbers. But there is a difference, isn't there? There is a stepwise difference, and that difference is meaningful and significant. So although they don't sound like huge differences, when you're talking about people's quality of life, they are. So that was an interesting finding, and one that we weren't sure whether we would be able to pick up. Certainly in previous research, we found that the relationship is not always as clear as that. So in terms of next steps, first thing I need to say is that you are our first audience that we're presenting the results to, and we're considering these emerging findings. So we've still got time to look at this data in more depth. So there is possibility that we might change some of the factors that we've included here today. So far, the focus with the CQC ratings there has been on current quality of life, so what people's lives are like now and how that relates to those CQC ratings. But do you remember I was talking earlier about impact? And that's something that we're going to be looking at next. So how does the impact the home is having relate to those CQC ratings? And do we get different results when we look at impact versus current quality of life? And we're wondering whether we may see a difference here with nursing and residential. So it'll be interesting for us to look at that in a bit more detail, partly because nursing homes are catering for a much frailer population. The other thing to add is that although this study has drawn to a close, we are starting a new project that will be being conducted in the South East across 4 different local authorities. And that project will be collecting data on CQC ratings and quality of life of residents again. And so when we finish that project in a couple of years' time, we will be able to bring the 2 data sets together and have a much bigger sample, which will give us greater statistical power to be able to come to more conclusions than we can on a sample of 34 homes. Also, because we will be including homes from other local authority areas, it will be more representative of the country as a whole. So we're constantly building on this data. And going back to the point about Margaret and the Enrich website, I think this is why we're also trying to encourage homes to engage more with research, because unless we can engage with you all and continue to engage with you all, we won't be able to keep building on this knowledge base and on this data. So before we take some questions, I just want to do some acknowledgements to people that have been involved in the project, because we wouldn't be here reporting these findings if it wasn't for everybody that's been involved. So first of all, to all the residents, staff and care homes and family members who took part, because without you we wouldn't have had the consent in the first place to collect the data. And the staff that took ages filling out questionnaires for us, so thank you so much to all of you. Thank you so much to our project advisory group, some of whom are here today. We've had Colin Jones, who's going to be talking at the end, from Kent County Council. Our CQC link for the project was Sarah Montgomery, who some of you may know. We've got Frank Ursel here from the Registered Nursing Home Association. Kathy's here, Kathy Chuck, a local care home manager. She was also on our advisory group. And Helen, you're here, yes. Helen Salisbury's here as well, representing Carer Support. And we had Brian Munday, who is on the board of Avanti Care Homes as well. So we've had some really valuable insight and knowledge on our advisory group, which has helped shape the project as we've gone along over the last 3 years. I want to thank our colleague, Stephen Allen, who isn't here today, but has given us lots of tips and advice when we've been tearing our hair out over some of the multi-level modelling involved in this project. And finally, just to recognise that although this project was funded by the NIHR School for Social Care, the University of Kent has helped fund this event today. So something called the Public Engagement with Research Fund has helped pay for the filming so that we can hopefully put this information online and reach care home residents, family members and managers and staff who weren't able to attend today but will be interested in hearing these results. So hopefully we'll be able to reach a wider audience. Finally, I have to do my last bit for the funder, which just says that this is our results and our findings, and that these views don't necessarily represent those of the funder or the Department of Health. Okay, so that's me done. So I'm open to questions before I hand over to Nick, if anyone has anything they want to ask. We were, but unfortunately our data for care home fees was not very good. So we have better data on whether people were self-funding or not self-funding, and that hasn't proved to be very useful in the modelling. But because and this is something actually that's quite interesting to discuss while we've got care homes here, is that despite having the consent process in place whereby people would be able to share fees information with us, we met quite a lot of resistance from home managers around sharing fees data. So we have so much missing information that we've not been able to look at it. So I think that's something that we need to consider in terms of future research and how we get around that, why people might feel more protective over fees information than they do around people's health information, which is quite interesting really. So yeah, so we've had some barriers, we've not been able to look at it. So we took the register of care homes that are registered for nursing and residential care for older people for Kent and Medway, and we did initially a random selection. So we literally every nth home from a list and sent out letters. And then what we always do, because initially we just basically send things in the post to people, and then what we then do is we give that a couple of weeks and then we start phoning. So and then what we then do is then meet with people. So actually it's a multiple pronged attack. So we start with letters, we work up to phone calls, then we have face-to-face meetings, and it takes that much reassurance. I mean, everyone else that was involved in this will know it takes that much reassurance sometimes to convince homes that what we're doing is okay and that we're not going to be doing anything awful and that it's not too intrusive. And I think that's where, you know, connecting and raising awareness of research, and partly why we've got managers speaking today, is to try and encourage other homes not to be too frightened of taking part in research projects like ours really, and reassuring you all that actually, although I've presented on the results today, all the data is anonymous. So there is no way that you could know which homes from what I've presented today took part, or which residents took part. And I think it's about building that confidence and awareness so that people feel more relaxed about doing it in the future. I suppose with larger chains, you do have a more corporate approach. And I suppose that's fair enough. But I think sometimes it can also be the opposite way around. So sometimes we've had buy-in from the organisation, but the organisation, I don't know, the regional manager or area manager has said, I'm in charge of these 6 homes and I want them to take part. And then get down to the individual home managers and they're saying, hold on a minute, I don't want to take part in this project, it's not convenient, I've got this going on or that going on. So I think sometimes it can also be the opposite way around. Yeah. Sometimes as a researcher, when you're trying to encourage a care home or any organisation or any individual person to take part in some research, you feel like a cold calling salesman in effect, because you're just approaching people, they don't know who you are, and you're trying to say, we want to come in and do all these things with you. And I can't really blame people for saying no. So I think drawing on those networks and having other people vouch for you and say, well, I've already taken part and they're fine, I think that goes a long way.